Hi Vicho, welcome to this session where I'm going to give you a recall of all the OBGY questions which were asked in INI-CET May 2024. Now these questions, they become important because for your NEET PG you should quickly revise these questions and the topics from where these questions were asked. See, the trend what has happened these days is that in INI-CET and NEET there is a lot of overlap of topics, and that is why these questions become very, very important for you. I know that, there is a time crunch at this time and you are looking for just quick recalls. So I am going to be really quick over here and I'm going to just tell you the relevant information related to each question. Now, in OBGY, the questions which were asked, they were, I would say, not that difficult, moderate level questions. And I am so happy to tell you that all 100% questions were from your marrow notes, right? So let's begin with the recall. Which of the following hormones is not required for fetal growth? So I have told you that hormones which are required for fetal growth are insulin, insulin-like factors, thyroxine. Growth hormone is the hormone which is not required for fetal growth. Growth hormone has to play a role only once the baby is born, right? So this is very much important. Now, few other things which you should be remembering are, what is the best ultrasound parameter which helps you in knowing about the fetal growth? So, best ultrasound parameter for fetal growth is abdominal circumference. But is it the best method for estimating the fetal weight or estimating the fetal growth? No, that's not the best method. Best method, if they ask you, then the answer is Hadlock formula or Shepherd formula. Right? Then if they ask you that can fetal weight be estimated clinically? Clinically, yes, it can be estimated. Clinically, it can be estimated using the Johnson's formula. Right? Now, as far as abdominal circumference is concerned, if abdominal circumference is more than equal to 35 centimeters, that indicates macrosomia, and macrosomia is weight of the baby more than equal to 4 kgs. Now, in this particular exam, a question on IUGR was also asked, which I'm also going to discuss with you towards the end. That's the last question which I will be discussing with you. Right? Then coming to the next question, 33-year-old G2P1 at 18 weeks was found to have high risk of neural tube defect and low risk of trisomy 21 on quad test. So all of you know that quad test is done in second trimester, and this is a method for screening of Down syndrome. Right? And what are the things which you are going to check in quad test? In quad test, you are going to check the alpha fetoprotein, you are going to check HCG levels, you are going to check unconjugated E3 levels, and you are going to check inhibin levels. Right? As I told you, in case of Down syndrome, H for HCG, H for high, I for inhibin, I for high. Rest alpha fetoprotein and unconjugated E3 levels are decreased, right? Now your question is saying that once a quad test, so what time is the quad test done? Quad test is done in second trimester and the time would be around 16 to 18 weeks. Right? Now, the question is saying that the patient has high risk of neural tube defect, which means that probably in the quad test you had got an isolated increase in alpha fetoprotein levels. And in class also I tell you, and in marrow notes also I have told you, that whenever there is an isolated increase in alpha fetoprotein levels, you are suspecting neural tube defects, which in itself is a structural defect. And for any structural defect, the next step is you have to do ultrasound. And which ultrasound? You have to do a level 2 ultrasound. So which ultrasound are you going to do? You are going to do a level 2 ultrasound. Right? And this level 2 ultrasound is TIFA, or which is also called as the target scan, or it is also called as anomaly scan. Right? TIFA stands for targeted imaging for fetal anomaly. This scan has to be done in all pregnant females also. So if during pregnancy, one ultrasound has to be done, it has to be TIFA, and it is done, the best time to do it is between 18 to 20 weeks, right? So in this case, I am going to go for anomaly scan. Just because your question is saying quad test, that does not mean you are going to go for amniocentesis beta. You are going to go for amniocentesis only if there is a risk for aneuploidy. And over here, it's a structural defect. It's not a risk for aneuploidy because the question itself is saying they have low risk of trisomy 21. So the answer is anomaly scan. Coming to the next question, a G2P1 delivered a baby via full-term vaginal delivery. The baby is 3 kgs and is active and plays well. Her blood group was found to be O negative and her husband's blood group was found to be B positive. She was given anti-D at 28 weeks of gestation. Which of the following will be appropriate situation to administer postpartum anti-D prophylaxis? So you all know that we have antepartum prophylaxis and postpartum prophylaxis. Antepartum prophylaxis is given at 28 weeks of pregnancy, right? And postpartum prophylaxis is given after delivery. Ideally, you should give it within 72 hours of delivery. But if your patient is unable to afford it and they are not bringing it within 72 hours, then you can give it up till 28 days after delivery. Right? Now, the dose in both cases is 300 micrograms. Either in your question, it will be written as 300 micrograms or it will be written as 1500 international units. Please remember, only if your patient is less than 12 weeks pregnant, then the dose of anti-D is 50 micrograms. Otherwise, everywhere else, the dose of anti-D is 300 micrograms. By what route are you going to give it? You are going to give it by IM route. What are the prerequisites? So, the prerequisite for antepartum prophylaxis. So, in antepartum prophylaxis, prerequisite is that the husband's blood group should be positive, right? So, husband should be Rh positive, right? Once husband is Rh positive, then I do an indirect comb test, and indirect comb test should be negative. Now, what are the prerequisites for giving postpartum prophylaxis? Fetal blood group should be positive. Fetal blood group should be Rh positive and your direct comb test should be negative. Now, the role of antepartum prophylaxis is to protect present pregnancy. So, whenever you have to protect the present pregnancy, you go for antepartum prophylaxis. Postpartum prophylaxis, it is for future pregnancies. Right? So, in this case, please remember, they are saying that when are you going to give? So, if baby blood group has to be O positive and direct comb test has to be negative. That means the answer is option A. Right? Now, suppose your patient gives you history of abruptio or there is trauma. Whenever there is history of abruptio or trauma, you should always suspect that a larger dose of anti-D would be required. And in that case, the test which you do, Kleehor-Betke test. That is the test which is done, which tells you that what dose of anti-D is required, right? So, please remember 300 micrograms of anti-D is sufficient to neutralize 15 ml of fetal RBC or 30 ml of feto-maternal hemorrhage, right? Okay. So, these were some of the important points. Coming to the next question. In the next question, we have an 18-year-old girl was brought to her mother presented with primary amenorrhea and acute retention of urine. She has cyclical pain in abdomen. Now, in your videos, I have clearly told you, beta, whenever a patient is coming to you with primary amenorrhea and whenever there is cyclical pain in abdomen, you have to suspect cryptomenorrhea. And for cryptomenorrhea, there are two very important causes. One of them is imperforate hymen, which is much more common than transverse vaginal septum. Right? So, the more common one is imperforate hymen. Now, the question further says a suprapubic mass and tense bluish bulge was seen in her vagina. So, local examination findings have been given and it is saying tense bluish bulge, which means that it has to be an imperforate hymen. What is the suprapubic bulge or suprapubic mass which you are getting? The suprapubic mass which you are getting can be number one, the full bladder. right? Because patient is saying that she has come to you with acute retention of urine, right? And in other cases, whenever you get a suprapubic bulge, that may also indicate hematometra, that is blood filled inside the uterus. Now, how do you manage imperforate hymen? Imperforate hymen, it is always managed by giving a cruciate incision. Right? Now, whenever in your questions local examination findings are not mentioned, then please remember, if both imperforate hymen and transverse vaginal septa are mentioned, you should always go for imperforate hymen. Or sometimes in your questions, they may give you the findings on per rectal examination. Remember that these girls are virgin females. That is why we don't do a per vaginal examination. We do a per rectal examination in order to see whether the uterus is bulky or whether uterus is present or not present. If I want to see in a female who's come to me with primary amenorrhea, I should do a per rectal examination, right? Now, in this patient, when I will do a per rectal examination, I am going to feel a bulge. Now, that bulge could be against the tip of my finger or against the pulp of my finger. If it is against the tip of my finger, that means the bulge is higher up, and that means it's a transverse vaginal septum. And if you are feeling a bulge on the pulp of your finger, which means the bulge is slightly lower, at a lower level, the obstruction is slightly at a lower level, and that means it's an imperforate hymen. So, on per rectal examination, if you are feeling a bulge at the tip of the finger, that indicates transverse vaginal septum. And if you are feeling it at the pulp of the finger, that indicates imperforate hymen. So, these are few practical things which you should keep in mind. Normally, you can differentiate a transverse vaginal septum and imperforate hymen by the findings, because in case of imperforate hymen, cough impulse will be present. Whereas in transverse vaginal septum, cough impulse will be absent. But suppose you are unable to differentiate between transverse vaginal septum and imperforate hymen in this manner, then you have to do MRI. MRI is the best method to differentiate between transverse vaginal septum and imperforate hymen, right? Coming to the next question. An 18-year-old female with 6 weeks amenorrhea presents with pain in abdomen and bleeding PV. Now, whenever you are getting amenorrhea plus bleeding PV, plus you are getting pain in abdomen, this is a typical triad which you get in case of ectopic pregnancy. All these questions we have already done, right? Then your question is saying she has hypotension and tachycardia. That means your patient is in shock. And they are saying on per vaginal examination, you are getting cervical movement tenderness. On ultrasound, free fluid is seen. So, all that points towards ruptured ectopic. Please remember that there are certain symptoms which I told you. See, this is a triad which you are going to see in case of ectopic pregnancy. Whether it is ruptured or whether it is unruptured, you are going to get amenorrhea plus bleeding PV plus pain in abdomen. Now, how do you come to know that you are dealing with ruptured ectopic? So, if they are talking about symptoms like, number one, if they say that their patient is having shoulder tip pain, Danforth sign. Shoulder tip pain, which is also called as the Danforth sign. Now, tell me, why are you going to get shoulder tip pain? Because there is hemoperitoneum. This blood is going to irritate the diaphragm. And when the blood is going to irritate the diaphragm, through the phrenic nerve, the referred pain will be in the shoulders. Then, number two, if your patient is complaining of orthostatic hypotension. And number three you can get is urge to defecate. Now, why do you get an urge to defecate? A ruptured ectopic. In ruptured ectopic, see over here, this is the bladder, this over here is the uterus, this is the rectum, right? So, this over here is pouch of Douglas, right? So, whenever blood is going to be collected here, it is going to push against the rectum, and that is why patient will have urge to defecate. So, these are the symptoms which tell you that yes, it is a case of ruptured ectopic. So, symptoms I have told you. right? UPT of the patient was positive, typical triad I have told you. Now on per vaginal examination, what findings do you get in ectopic pregnancy? On per vaginal examination, the findings which you get in ectopic pregnancy, size of the uterus is less than the period of gestation, number one. Number two, a very, very important finding is cervical movement tenderness. That's very, very important finding. Please remember, in obs and gynae, you get cervical movement tenderness at two places. One is ruptured ectopic and the other one is PID. That is why before you hand over the PID kit to any patient, you should always ask them about their LMP. You should always do a urine pregnancy test or beta HCG if they have missed their periods. Then you should be telling them that they have PID and handing them over the PID kit, right? Because in both PID and ectopic pregnancy, you get cervical movement tenderness, right? So on per vaginal examination, these are the findings which you get. Then, whenever these findings are together, as I told you, if you are getting a typical triad of ectopic pregnancy, UPT positive, if your patient is in shock, or there are symptoms like urge to defecate, like orthostatic hypotension, syncope, or like shoulder tip pain, plus the size of the uterus is less than POG, cervical movement tenderness is present, it means you are suspecting ruptured ectopic. Now, whenever you are suspecting ruptured ectopic, your next step should be per abdominal examination, and through this per abdominal examination, you have to see whether the localizing signs are present or not. Localizing signs are guarding and rigidity. Right, so look at it whether guarding and rigidity are present or not. If guarding and rigidity they are present, that means a ruptured ectopic is confirmed. Ruptured ectopic is confirmed. There is no need to do any ultrasound. Right, and your next step becomes that you have to go for the surgical management of ruptured ectopic. But just in case these localizing signs are absent, then in that case you will do a fast ultrasound, and if ruptured ectopic is confirmed, then you are going to go for surgical management of ruptured ectopic. Now, what is the surgical management of ruptured ectopic? Surgical management of ruptured ectopic is you have to open the abdomen either by laparotomy or by laparoscopy. You are going to do laparotomy if the vitals of the patient are unstable, and laparoscopy only and only if vitals of the patient are stable. Now, this is how I open the abdomen. What surgery am I going to do? I am going to do a unilateral salpingectomy, irrespective of the fact whether the patient's family is complete or not. Irrespective of family complete or not. Irrespective of that fact, you have to do salpingectomy. Please remember, in ruptured ectopic, there is no role of medical management, no role of conservative management, no role of surgeries like linear salpingostomy. You are not going to answer linear salpingostomy. I have told you in videos and in revision videos repeatedly that the management of ruptured ectopic is unilateral salpingectomy. Because ectopic pregnancy happens in young females, you never remove the ovaries. Salpingo-oophorectomy is never done unless and until it's an ovarian ectopic. Obviously, then you have to remove the ovaries, but otherwise you don't remove the ovaries. Right? Then, which of the following is not possible? This is a very, very easy question. Okay, so this question I have explained you always in the videos also, that chorion is formed between day 4 to day 8 and amnion is formed by day 10. Please remember the way I have taught you in class. I told you that, remember, dizygotic twins means each twin was formed by 2 ova, 2 sperms, 2 zygotes. Now, and each zygote between day 4 to day 8 will form its chorion, and each zygote between and on day 10 is going to form its amnion. That means in dizygotic twins, they are always dichorionic, diamniotic. Now, when it comes to monozygotic twins, monozygotic twins में there is a single ova which is fertilized by single sperm and a single zygote is formed, and then this zygote divides into 2. So depending upon the time of division, they could either be a single chorion or they could be 2 chorions. So suppose there is a big ball and this big ball divides into 2 small balls at less than 72 hours. Right? That means in morula stage. So because it is dividing in less than 72 hours, each of these small balls between day 4 to day 8 will form its chorion, and on day 10 is going to form its amnion. That means the twins will be dichorionic, diamniotic. Now, number 2. if division is happening between day 4 to day 8 after fertilization. Now, understand, there is a big ball. This big ball already has formed its chorion between day 4 to day 8, and then it is dividing into two small balls. So these two small balls will be surrounded by a single chorion, and each of the small ball will form its own amnion. That means the twins will be monochorionic diamniotic. Right? Now, if division happens between 9 to 12 days, now imagine this big ball between day 4 to day 8 will form its chorion, and by day 10 will form its amnion. Now it is going to divide into two small balls. So both the two small balls will be surrounded by single chorion, single amnion. That is monochorionic, monoamniotic. And if division happens at more than equal to 12 days, then it is conjoined twins. Right? So this is how monozygotic twins are formed. Remember, the most common twins are dichorionic, diamniotic, because 80% of the twins are dizygotic, and dizygotic are always dichorionic, diamniotic. And if they ask you most common variety of monozygotic twin, the most common variety of monozygotic twin is monochorionic, diamniotic. So over here, which is not possible? Monochorionic, monoamniotic is possible. Monochorionic, diamniotic is possible. Monoamniotic, dichorionic is not possible, and dichorionic, diamniotic, that's the most common type of pregnancy. Now tell me, in dichorionic, diamniotic twin pregnancy, always please remember, DCDA always have better prognosis than monochorionic twins. What are the complications which are specific? And this was one of your NEET PYQs. Complications which are specific to monochorionic twins. What complications are specific? So, twin-to-twin transfusion syndrome, number 1, twin anemia polycythemia sequence, and twin reversed arterial perfusion, and selective IUGR. Selective IUGR means only one twin has IUGR. So these are the 4 complications which are specific to monochorionic twins. Please remember that the prognosis of twin pregnancy depends on chorionicity. It does not depend upon zygosity. What is the investigation of choice to know about chorionicity? The investigation of choice is TVS, which should be done between 10 to 14 weeks. What are the signs of dichorionicity on ultrasound? Signs of dichorionicity on ultrasound are, number 1, if the sex of the babies is different. Number 2, if there are 2 placentas. Number 3, if there are 4 layers of membranes which are present between the twins. Number 4, if there are thick membranes which are present between the twins. And number 5, twin peak sign will be positive. Twin peak sign is also called as lambda sign. Now, out of all these 5, the most important one are 2 placentas. This is the most important one. And the second most important one is sex of the baby is different. Right? So, these are the complications which were there only in monochorionic twins and signs of dichorionicity on ultrasound. Clear to all of you? Okay. Now, next question. Okay, so what is the correct dose of administration of antenatal steroids? So, betamethasone, what is the dose? Betamethasone, the dose is 12 mg 24 hours apart. You have to give 2 doses. Right, whereas in case of dexamethasone, it is 6 mg 12 hours apart, 4 doses. Right, so these are the doses of betamethasone and dexamethasone. So 6 mg 12 hours apart, 4 doses. Now, what is the indication for giving corticosteroids? The indication is any pregnancy which is less than 37 weeks, you have to give corticosteroids, right? Number 1. Number 2, please remember, the only contraindication for corticosteroids is chorioamnionitis. Right. Number 3, please remember, if corticosteroid has been given earlier in pregnancy. So, suppose there was a patient who came to you in preterm labor at 32 weeks of pregnancy and you gave her corticosteroids and her contractions stopped and she went back home. Now, again she is coming to you at 35 weeks with contractions. Now, you don't have to repeat a course of corticosteroid. The course of corticosteroid at no cost should be repeated. Right? Have you understood this? Then corticosteroids, they take at least 48 hours to act, and that is why if pregnancy is less than 34 weeks and your patient goes into preterm labor, then along with the corticosteroid, what do you give? You have to add tocolytics. Tocolytics are never added at more than equal to 34 weeks. They have to be added only at early preterm labor, that is at less than 34 weeks. And the role of tocolytics is to buy time for corticosteroids to act. The tocolytic of choice which we use in India is nifedipine. Right? Please remember, endomethacin is also a tocolytic, but it should be used only at less than 32 weeks, because if you use endomethacin at more than equal to 32 weeks, it leads to premature closure of ductus arteriosus. Right? Okay. Next question. In a hypertensive patient presenting with PPH, which drug is contraindicated? So again, this is directly from your notes. I told you that methyl ergometrin, we have done the mnemonic TOPER, and I told you methyl ergometrin, it has got two important characteristics. It leads to tetanic contractions of the uterus, and number two, it leads to hypertension, and that is why its contraindications are after delivery of first twin, you should never give it. O stands for organic heart disease, and that is just for the mnemonic sake that I am telling organic heart disease, otherwise it is any heart disease. P stands for peripheral vascular disease, E for eclampsia, preeclampsia, and PIH, and R for Rh negative pregnancy. Right? Now, other important things which I want you to remember, are number one, as I told you, methyl ergometrin leads to hypertension. Number two, oxytocin, if you give it IV bolus, it leads to hypotension, bradycardia and cardiac arrest, and that is why it should never be given IV bolus. Right? Then it should always be given in the form of IV infusion, and that IV infusion should be prepared in electrolyte-rich media. If you prepare its IV infusion in dextrose 5%, it leads to water intoxication. Then we have PGF2 alpha, which is also called as carboprost, dinoprost or Hembate. It is contraindicated in asthma patients, amniotic fluid embolism patients and pulmonary hypertension patients. Its relative contraindication is hypertension. An important point about carboprost is it is the best drug for managing PPH, but then we don't use it for managing AMTSL and for induction of labor. Now, side effect of carboprost, it leads to diarrhea, and how much carboprost are you going to give? You are going to give 250 micrograms, and maximum you can give 8 doses in 24 hours. That means maximum you can give 2 milligrams IM. Then please remember about misoprost. Misoprost is contraindicated in previous cesarean section patients, and its side effect is it leads to hyperpyrexia with chills. Right? So these are important points which you had to remember. These are all the important things on the drugs along which you have to remember. For example, carbetocin, it is never used for managing PPH. It is always used in management of AMTSL. And in AMTSL, the dose of carbetocin is 100 micrograms slow IV. Many times you people confuse between carbetocin and carboprost. Please remember, carbetocin is oxytocin analog. It's an synthetic oxytocin, right? Whereas carboprost is PGF2 alpha. Right? Carbetocin is used for AMTSL, carboprost is used for managing PPH. Right? Okay. Then a 32-year-old female at 36 weeks of pregnancy presents with 170 by 100 millimeters of mercury BP. There are visual disturbances, headache, and urine is 3+. What is the next step? So, patient is having proteinuria plus she has got 170 by 100 millimeters of mercury, which means she comes into the category of preeclampsia. And which category of preeclampsia? Severe preeclampsia. Now, your question further says that she has visual disturbances and she has headache, which means that your patient is severe preeclampsia with impending eclampsia. Now, whenever there is an impending eclampsia, definitely my first step is to prevent her from having seizures, which means you are going to give magnesium sulfate. Magnesium sulfate is the drug of choice not only for treating seizures but also for preventing seizures. So my first step is magnesium sulfate. Then my second step is I am going to give her IV labetalol so that she doesn't have intracranial hemorrhage. And my third step would be to give her corticosteroid, right? And then my definitive management is in impending eclampsia. You don't have to wait. You have to go for immediate termination of pregnancy. Right, so over here the answer is option A. Right, corticosteroids are essential beta, but then more important is labetalol and magnesium sulfate. Magnesium sulfate being the top priority, right? You can't wait to deliver at 37 weeks. Why? Because it's a case of impending eclampsia. In impending eclampsia, you have to deliver immediately. Okay, which mineral causes hypogonadism and delayed sexual maturity? Again, I have taught you this in class, that the mineral which is required for the formation of gonads properly and for sexual maturity is zinc. Right, so the answer to this question is zinc. Coming to a very controversial question which was asked this time, that is a G2P1 female came at 40 weeks of gestation with labor pains and in second stage of labor for the last 2 hours. On examination of abdomen, there are 4 contractions per 10 minutes, each lasting for more than a minute. On pervaginal examination, station is +3, sutures were in AP diameter and caput was present, fetal heart rate 70 beats per minute since the last 20 minutes. What is the appropriate method of delivery? Now, please understand that number one, this patient is G2 patient, right? And she has been in second stage of labor for 2 hours, right? Now, please, if in a primary patient, if she stays in a second stage of labor for more than equal to 3 hours, and in multi-patient, if she stays for more than equal to 2 hours, then that becomes a case of prolonged second stage of labor. On top of that, question is saying that fetal heart rate is 70 beats per minute, which means there is fetal distress. Now, how do you manage a case of fetal distress in second stage? I have taught you in class that a case of fetal distress in second stage should be managed by looking at the station. If station is above +2, then I have only one option, that is cesarean section. If station is +2 or below it, then I can use forceps or vacuum. Better is forceps. In this case over here, because question is saying that a caput was present, so definitely I am not going to use vacuum. I am going to use forceps. Now, in forceps, the type of forceps which we are using these days are either outlet forceps or low cavity forceps. Now, earlier when I gave my earlier recall, I did not see that over here AP diameter was, the sutures are in AP diameter was mentioned. Now, please understand, at +3 station, your books say that if station is +2 or below and reaching up till +3 station, you have to apply low forceps, right? And more than equal to +3 pay, you have to apply outlet forceps. Now, at +3, you can either apply low forceps or you can apply outlet forceps. The criteria over here which we are going to take is, because your question is saying that the sutures are in AP diameter, that is why I am going to now make my answer as outlet forceps rather than low cavity forceps. Only and only because of this reason, because the question is saying that the sagittal sutures are in AP diameter, right? So the answer is going to be outlet forceps. Otherwise, your books mention that it could be any of these two things. At +3 station, it could be low forceps or it could be outlet forceps, right? So +2 or below that it is written as low forceps, and outlet forceps specifically they say that the scalp should be visible at the perineum, head should be at the pelvic floor, and you should be able to see the fetal head without separating mother's labia. That is when you apply outlet forceps, right? So over here now the answer is becoming outlet forceps only because of the reason that AP diameter, the sagittal sutures are in AP diameter. Now, in normal physiological condition in a reproductive age female, what is the most potent estrogen? This is a very simple one we've done in class, that the most potent one is E2 followed by E1 then E3. That is physiologically, that is natural estrogen. But when you compare both varieties of estrogen, that is synthetic and natural estrogens, then the most potent is ethinyl estradiol followed by conjugated equine estrogen, then E2, then E1, then E3. Now, please remember, ethinyl estradiol is used in OCPs. Conjugated equine estrogen, it was earlier a part of HRT, and now 17 beta estradiol is a part of HRT. right? So this is how the potency of natural and synthetic estrogen varies, because your question was very specific in asking about natural estrogen. So the answer over here becomes estradiol. Okay, so a 16-year-old female came with complaint of primary amenorrhea. She had normal secondary sexual characteristic. Breast corresponded to Tanner stage 4. Her FSH, LH values are given as 5.3, 12.1, which are approximately normal. Normal is between 1 to 10. Her karyotype is 46XX. What is the diagnosis? Now let us rule out. See, can it be a case of androgen insensitivity syndrome? No. Why? Because in androgen insensitivity syndrome, the karyotype is 46XY, number 1. Number 2, what happens to LH-FSH values in androgen insensitivity syndrome? In androgen insensitivity syndrome, LH levels are high, FSH levels are normal, right? Another very important thing which you have to remember is that same finding you get in patients of PCOS. So remember, androgen insensitivity syndrome's hormonal profile and PCOS hormonal profile is similar. In both of them, LH levels are high, FSH levels are normal. Androgen insensitivity syndrome leads to primary amenorrhea, PCOS leads to secondary amenorrhea. Now, can it be gonadal dysgenesis? No, it cannot be gonadal dysgenesis. Why? Because in gonadal dysgenesis, beta, number 1, secondary sexual characteristics would be absent because the gonads are not functioning. That is why estrogen is less. And if estrogen is less, the negative feedback on LH, FSH would be gone. So, there will be increased LH, increased FSH. Right? Then comes, what about Kalman syndrome? In Kalman syndrome, what are you going to get? In Kalman syndrome, now again, secondary sexual characteristics would be absent. Why? Because GnRH is decreased. If GnRH is decreased, FSH decreased, LH decreased. So again, it cannot be Kalman syndrome. So my answer over here is Mullerian agenesis. Right? Next question, which of the following is not a criteria to diagnose IUGR? Now, here I want to tell you that there are, other than that, the expected fetal weight or the estimated fetal weight is less than 10 percentile. There are other criteria which are now being used to define IUGR, and neonates are now classified as very small for gestational age if their weight is less than, weight is less than 3 percentile, small for gestational age if their weight is less than 10 percentile, and appropriate for gestational age if their weight is between 10 to 90 percentile, large for gestational age if their weight is more than 90 percentile. Have you understood? So, very small for gestational age if weight is less than 3 percentile, small for gestational age if their weight is less than 10 percentile, appropriate 10 to 90, large for gestational age more than 90. So, yes, if estimated fetal weight is less than 3 percentile, that comes under very small for gestational age. Similarly, if abdominal circumference is less than 3 percentile, that is also taken as very small for gestational age. Now, absent diastolic flow in umbilical artery, yes, absent diastolic flow in umbilical artery again is a feature which can help you in making diagnosis of uteroplacental insufficiency, and uteroplacental insufficiency in turn leads to IUGR. Now comes the fourth thing, uterine artery pulsatility index less than 95%. Uterine artery pulsatility index. Now, first of all, please remember, uterine artery Doppler is not the one which is used for diagnosing IUGR. Right? It is not the uterine artery Doppler. Right, number 1 important point. Uterine artery Doppler is used for PIH. It is not for, it helps you in predicting PIH. For prognosis of PIH, that is uteroplacental insufficiency or IUGR, you are using umbilical artery Doppler. I want all of you to understand the Doppler indexes in IUGR. Please remember, when you combine fetal biometry along with Doppler, that is the best way of identifying small fetuses at risk for adverse outcomes. Before 34 weeks, you have to look at umbilical artery Doppler, and you have to look at the pulsatility index of umbilical artery Doppler. Now, in case of umbilical artery Doppler, the pulsatility index would be high. What do you mean by pulsatility index? Systolic peak velocity minus diastolic peak velocity divided by average velocity. Now, because diastolic velocity is decreasing in umbilical artery, the blood flow in patients of IUGR, the blood flow in umbilical artery would decrease. right? Why? Because blood coming to the fetus is decreasing through umbilical vein. So blood going to the umbilical artery would also decrease, and that decrease will be seen more during diastole than during systole. So numerator is increasing. Systole minus diastole will increase. So pulsatility index would increase in umbilical artery in case of IUGR. So in early cases, you have to look at umbilical artery and you have to look at the pulsatility index and resistance index, which is going to increase in case of IUGR. Now in IUGR, all of you know that there is a brain sparing effect, right? So the blood from all the organs is collected and sent to the brain, and when blood from all the organs is collected and sent to the brain, so blood flow during diastole increases, and because blood flow during diastole increases, so systole minus diastole would decrease. That means the numerator is decreasing. So what happens to the pulsatility index of middle cerebral artery in IUGR? The pulsatility index of middle cerebral artery in IUGR would decrease, and that is a late sign of IUGR. Right? So there are two arteries in which you have to look for early changes. You have to look at umbilical artery Doppler, where the indexes would increase, and for later changes you will have to look at middle cerebral artery Doppler, where the pulsatility index or the resistance index would decrease. Right? There is no role of uterine artery Doppler in case of IUGR. Clear? It is only there to predict IUGR, right? And even for prediction, the pulsatility index would increase in uterine artery Doppler rather than decrease. Have you understood better? So that is all what you have to know in the INI-CET recall. I hope this is going to be beneficial for all of you, and I hope all of you are going to do really well in your upcoming NEET exams. All the best to all of you. Thank you so much.